Hello and welcome to today's webinar, Case Profile, Achieving Bidirectional Data Exchange Between Plans and Providers. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box that you see located on the right side of your screen and pressing enter there. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Stephen Burko, Head of Value-Based Market Strategy, and Kerry Lockhart, Customer Service Manager, both at InterSystems. So at this time, I'd like to turn the floor over to Stephen.
Thanks, Chris, and I want to thank everybody on the line who made time today to explore what's needed to achieve bidirectional data exchange between plans and providers. On the screen is actually a report from the National Academy of Medicine talking about interoperability. This is the outfit that published the groundbreaking report on quality, crossing the quality chasm. And looking at the screen, you can see their take on interoperability. Our healthcare delivery system requires unprecedented access to health information in order to effectively and efficiently provide the best care to individual patients and entire populations. But dropping down to the bottom, true interoperability remains an elusive goal. And it's been a minute since this report was published, back in 2018. But the lion's share of the progress that we've seen in the interim is among providers rather than between providers and payers. And I want to give you a sense of what we, InterSystems, commonly confront when we start working with a plan and its network providers. So just the principal pitfalls that we see when we kind of walk in the door. So one, there's just still a lot of chart pulls and even a growing number of chart pulls, despite the fact that much of this information now resides in an electronic document or format somewhere. Also, a lot of post hoc clinical documentation, because we don't have an efficient way for the information to flow, that by the time the clinical information gets into the hands of the care manager or the right person, all too often it's too late to actually inform the care or the care episode of the individual member or patient. And there's just a lot of siloed and duplicative workflows, or more specifically, we might be in a situation where we're working with quality and they are getting data to inform their HEDIS scores or other things. And then when we start working with risk adjustment, we discover for some reason they're not privy to that data, and back to the top, they're requesting charts to get information they already have. What's remarkable is that there are now technological solves to all of these pitfalls. And again, I just want to give you a sense of what's now possible out in the marketplace. I mean, these are not demos. I mean, these are in place at leading plans. So we're working with leading plans who have what we would call a true clinical data repository, one place that can ingest clinical information in multiple formats and then push it out for multiple applications. These systems are capable of triggering alerts based on the clinical data that comes in to push the appropriate notification to the appropriate person within the plan or the provider. And together, these types of stuff we're starting to see really enable true data-driven care management. And this is really where Medica, our case study institution, comes into the story. And I'm actually going to turn it over to my colleague, Kerry, who's not just an expert on interoperability and the success manager at InterSystems, who's been working directly day in and day out with Medica on this. She also happens to be, I don't know, am I allowed to say a former frontline nurse? I've been schooled that once you're a nurse, you're always a nurse.
Yeah, I think former is fine. It sounds sad to me,
But I always like working with Carrie because she really brings kind of a deep understanding of kind of what the situation is on the ground and what these workflows can and should be. So with that, Carrie?
Thanks, Stephen. Hi, everybody. So glad you guys are here today. So I get to share a little bit more about Medica with you. So just from a case profile, they are a non-for-profit that serves the upper Midwest. They have about 1.4 million members across 8 states. And as you can see, a really large provider network. It is important to note for this case study that a majority of those providers are in the Epic EHR. But what Medica set forth and the visionaries that we were so privileged to work with really decided that in order to make an impact and reposition themselves, they needed to increase provider connectivity, they needed to increase data ingestion, and they also needed to increase the usability of that data, right? Because large volumes of data that aren't usable is not helpful. So they believed that that vision together was a foundation for them to have a big impact on the business. Now, that being said, that was not without its own challenges. This was not an easy layup for Medica. They're facing many of the same challenges that you are and health plans across the country are. You know, they have these disparate systems that are creating, we won't even see data lakes anymore. We'll say data ponds, where there's these pieces of information that without the other ponds together are not usable and actionable insights. So I think everybody's facing that. They have these legacy systems, some of which are proprietary, that are very embedded in business process and incredibly difficult to disrupt. They have this huge suite of vendors that come with a variety of sophistication. There's not a one size fits all to connect with these vendors. And then our visionary that we worked with on Medica used to say the only thing standard about the standards is that there isn't one. And we know those are going to continue to evolve and change over time. And of course, everyone's in a different place and different stages in provider relationship building. So from some very trusted providers that you already have a data sharing process with through the provider groups that won't call you back. So everyone's up against these big challenges. And I think what's important to call out here is that even though these challenges exist, I think a lot of plans see these as barriers or blockers to walking through this more holistic version of themselves, and it's doable. And Medica was very smart in how they broke down this work to take this on. It's not a bite it off all at once. And so Stephen and I are going to walk you through what that looked like. Stephen, I'll hand it over to you to start to show the vision of what we built. Oh, you're on mute, my friend.
I said if it hasn't occurred to everyone, Carrie and I are in totally different places.
Yeah.
What I want to do across the next couple of minutes is just give you a sense of Medica's start point and how they envisioned kind of bridging the gap to enable true bidirectional exchange. So on the screen, the start point, I think it's pretty universal. Over on the left, you know, for a typical plan in your network, you've got a lot of providers and they're on different EHRs. Now, as Carrie alluded to, one thing that is notable about this case study is that Medica did have the lion's share of their providers using Epic, and we've tried to capture that in the graphic. And then all the way over on the right side, all those legacy systems and functions that in effect want to be talking with and to the providers through their natural workflows. So let me walk you through how Medica envisioned bridging this gap. So it starts with Epic Payer Platform, and they licensed Epic Payer Platform, and what that enabled them to do was to dramatically reduce the number of endpoints they had to connect with. So instead of having to directly connect with each and every provider instance, the plan could effectively connect with Epic Payer Platform, and then Epic Payer Platform is connecting with all the Epic providers. But you still see that gap there, right? Medica's aspiration was not to be able to just simply look into the Epic environment and see all the information. They wanted to pull this information out and push it into their back-end systems, and vice versa. They wanted to take the insights from their back-end systems and then push it to their providers via Epic Payer Platform. And that's where InterSystems really comes into the story. The next piece they licensed was InterSystems Payer Connector. And let me be clear, this is a companion product we've built specifically to go with Epic Payer Platform. It's actually in the Epic showroom. And what it does is it, in effect, includes a lot of pre-built connectors that automate the ingestion and the push to of all the information back and forth with Epic Payer Platform, because a lot of that information is coming out in different formats, and to push information in, there's a number of proprietary Epic specifications that one has to meet. And then, interestingly enough, in terms of pushing the information into their back-end systems, Medica opted to put a CDR, a clinical data repository, between Payer Connector and their own systems. And the thinking there was they didn't want to have to create one-off connections between Payer Connector and all the individual systems. They wanted to have everything flow into one digital source of truth that could be readily tapped by multiple different back-end systems. Now, I want to put a pin in the clinical data repository. You can see they use STARS, HealthShare. I want to talk a little bit more about, regardless of whether you're using HealthShare or you have a CDR or you want to pair kind of Medica strategy with other CDRs, what are the kind of requirements you have to meet. But the first thing I wanted to note was also kind of in the blueprint is Medica did want to ensure that providers who were using other EHRs were kind of being included in this ecosystem. So they also licensed a connectivity solution to be able to pull in information from other EHRs and then push that into the clinical data repository. And I will tell you again, going back to what Carrie said, this blend between vision and pragmatism, at least up front, they focused us on being able to ingest this information to be able to populate it into their back-end systems. So it was a little bit one way as opposed to the two-way with the Epic providers, but that is just first iteration. On their longer-term game plan, they definitely want to create the same two-way or bidirectional exchange with providers on other EHRs. That's just a little bit farther down the road. All right, let's provide a little bit more information on when we say clinical data repository, what do we in Medica mean? And the reason why I wanted to double click here is I've just seen this term used interchangeably with a lot of other terms. I've seen people kind of, liken it to a data warehouse, or I haven't heard data pond, but that's a new one for me. A longitudinal health record in different terminology. And I don't want to kind of spend our time having a semantic conversation. So we thought what would be easier was just to include the list of requirements that we came up with Medica in terms of what this CDR clinical data repository must be able to do to support this vision. There's a lot of stuff here. I think it's I almost encourage people to mentally dog ear this slide, maybe go back to it when the recording is released. In the time we have, I just want to call out a couple of requirements that I think it's important that people not lose sight of. So number one, under ingestion, I think you have to be sure that your CDR isn't just able to, ingest the information in different formats and via different protocols, but there is some evaluation up front of what is being ingested, because you don't want to have a situation where, you kind of get to the end of everything and you want to deploy this stuff and you're missing a couple of key pieces of information that are critical to making everything else make sense. Under transformation, I do think it's important for people to begin to recognize that harmonization and normalization are different things. And it is important that your CDR is adept at doing both. Under activation, I do want to call out people's attention to that final bullet point. Yes, it's good to have a good user interface into your CDR. We have one. It's AI enabled, but also kind of the real kind of home run, if you will, is for your CDR to be able to push the relevant information into your legacy system. So, for example, if you're a health plan and you have case managers, almost all the health plans we work with, their case managers are using an existing system. And they don't want to be asked to come into the CDR. No, they want the CDR to push information into their system so it appears within their natural workflow. And then the last thing I want to call out is scalability. It is really important that your CDR be able to support, more and more volumes over time with no erosion in performance. Because if you go back to Medica's vision, if this is really going to work, we're going to be pushing more and more information through the CDR. And you want to be sure it can handle it, so you continue to get a bigger and bigger return on your investment. So that was my quick take on when you're thinking about, this is my shopper's guide to a CDR, if you will. I don't know, Carrie, if you want to add anything.
No, I'm sure we've thrown a lot at all of the listeners on the line here between this multi-point architecture and this large list of key capabilities. So I think it's important to remind everyone what you said, which was Medica's visionaries really came at this with both the vision and then a real life common sense approach about how do we phase this out and implement it in a way that is valuable building over time. And so I'm just going to take it and start to walk everybody through what that implementation looked like. So foundational to all of this, Medica was very clear with us that they needed up-to-date member enrollment files that they could share, right? The providers and the plans need to understand who they can communicate on. And interestingly, when we were building the success story, the business leaders at Medica let us know that when they went to the market and looked for vendors to work with to build out this vision and solution, this was something that was unique to InterSystems, this capability. They struggled to find this across other vendors. So it was really foundational to how they landed with us, and we became great partners. Once you have that foundational layer of that up-to-date member enrollment, then they started to really phase in the value over time. Phase one, as we talked about in the beginning, was start to ingest clinical data and start to make that real time and enable notifications to the coordination teams and others so that they could really take action on it, but building out that data asset and that longitudinal record, right? So that's phase one. And once they got through phase one, they really started talking about this bidirectional piece. That's where, they explored the value deeply about what can they do in between Epic Payer Platform and us. And I think, this is about taking data, transforming it, creating knowledge, and being able to send it back to the providers, to the right people at the right time so that they can actually have an impact and take action. So that could be, prepping for a visit or actually during an encounter and embedding it right into the provider's workflow. We're not asking the providers to go out and look somewhere else. It's there. Those coding gaps, those care gaps are there so that the providers can really walk forward and have an impact. And that brings us to phase three, where we are right now. Medica is actively implementing electronic prior authorization. They have goals to continue to move forward this sort of unified care coordination model where we're decreasing duplication of efforts across the continuum of care, but also just being able to get those actionable insights and really move things forward to impact their business. One of the really cool pieces that we talked about with Medica's visionary, which hits my nursing heart, is this idea that we've now built this data asset that's driving all this information and knowledge to our internal teams. We're starting to bidirectionally share it with the providers and get them insights. Wouldn't it be great if we can start to pull the member into this and really start to bring those same insights and knowledge to them? And so Medica has on their vision to really start to find a one-stop shop for members, where a member can come into a portal, see their provider information, see their plan information, and have this very holistic view. So that's one of my favorites on this sort of phased approach. So this is a great image. We all know that when we kick off big projects like this that are resource intensive and take a lot of time and effort for the plans, that it's important to be able to show value. And so this image that you see here is Medica within the first 4 to 6 weeks of turning this solution on. They had connected with 5 provider health systems, and they were smaller systems. They weren't even Medica's big bunches. Those 5 systems enabled them to see 11% of their members' clinical data. So really empowered them to be able to show a multiplier as they move forward, how much data and how many members would be covered within that data as they grew this out. I think today they're closer to about a dozen and have captured actually some of those really big health systems that they knew were going to be the bulk of their membership. So this really just shows you that even early on, you can start to get some value and really be able to demonstrate that and see it. This is back to our favorite slide again, Stephen. I think we've talked a little bit now about the operational aspects of how we phased the approach. This is that big overarching architecture. I think what Stephen and I thought would be helpful now was to work the mechanics of this and really start to show you during that phased approach how different pieces of this came to life. And so we're just going to start to walk through what that looks like. First step, build out the data asset, ingest more data, normalize it, make it usable. And so what you see here is the payer connector enabling Medica to connect back to Epic Payer Platform. And there's a multitude of messages and documentation that they're getting and ingesting. But what's super powerful about this is as they ingest it and normalize it and transform it, if you put this list together, what you end up getting is like over 700 discrete data elements. So I think we all know how powerful that can be. And what we see often with the health plans that I work with is they come to us with this interoperability idea that has a few use cases behind it. But once they start ingesting this type of clinical data and really making it usable and transforming it, normalizing it, and storing it, sky's the limit, right? So what I hear from our health plan business leaders often is we set out to do these few use cases, and now the business teams are starting to see the power of the data that we have, and there's another knock on the door every day and a new use case. Just this week, it's only Tuesday, and I've heard 2 new use cases that plans are enabling right now that they didn't even know would be within these data sets. So that ability to really take all of it and store it and normalize it has been incredibly powerful for them. Stephen, I'm going to let you walk through the rest of the mechanics.
So just to ground everyone, so what Gary was talking about was effectively phase 1. So we were still kind of unidirectional. And even there, what Gary's talking about, a lot of people seeing use cases in terms of how the back-end plan systems and operational functions can leverage that data. Now, with phase 2, hold on to your hats, everyone. We're going bidirectional. So they really, and again, what we really respected with Medica, this great kind of marriage between vision and practicality. And so what they said was, let's focus on 3 principal use cases. That's what we want to pull forward. So I'm just going to walk through those 3 principal use cases that we've been working on with them. So use case number 1 is just equip provider with a more comprehensive or broader medical record of their patient as they're seeing that patient. So our story here starts with the CDR, with HealthShare, which now has all this information. And the point is, let's now push it back to the provider via Payer Connector, via Epic Payer Platform, when the physician or other provider is about to see that patient. So again, I alluded to this before. So HealthShare pushes the relevant information that is associated with that member or patient to Payer Connector. And here's the critical point. Payer Connector is able to push that into Epic Payer Platform. And as we discussed before, there's a number of proprietary specifications that need to be met for Payer Platform to be able to ingest that information. And all that is pre-coded with Payer Connector. And then the end result is then Payer Platform can then expose that information in an electronic report within the Epic EHR called the health plan clinical summary. So use case number one. Use case number two is kind of almost a specific application of use case number one, and that is timely updates on risk adjustment coding gaps. So again, we're going to start our story with HealthShare, the CDR, and a little bit of a different waggle here. HealthShare now is going to push the information, or is pushing the information, into Medica's back-end risk adjustment systems, and which shows it to their own people, and I think some of their other vendors in the risk adjustment space. And then they're able to come up with insights, or more specifically, come up with a list of possible coding gaps, which go back into HealthShare. Then what happens is HealthShare via Payer Connector meets the specs to push that into Epic Payer Platform, which then again exposes that information to the physician or other provider within their existing workflow at the point of care via health plan clinical summary. One more use case, again, just three. And this is notifications to trigger patient care gap closure. I'm guessing a number of you are catching on how this works now, but I think the interesting thing here is now HealthShare is communicating with a different back-end system, a proprietary system that Medica is already relying on. So Medica's existing workflow on the back end for identifying care gaps. So clinical data that HealthShare's already connected via Epic Payer Platform, and sometimes via that connectivity solution with other HRs, pushing that into the quality engines. Those quality engines are turning that data into insight. What are the possible HEDIS gaps? Then going to push that information to Epic Payer Platform. Here it's a flat file, that's their current spec. And then Epic Payer Platform can ingest this and then surface it at the point of care to the treating provider through reports, electronic reports they call our practice advisory and or health maintenance reminders. And for those on the line who are either providers or responsible for dealing with your provider network, I think everybody knows this is what we really need to enable clinicians to act on our information. This is what we hear time and time again from providers. If you want us to act on our information, less is more. Give us exactly what we need at the right point in time within our existing workflow, and then the likelihood that we will act on that information dramatically shoots up. I don't know if you want to add anything to that as a former frontline provider, Carrie.
No, I mean, I think it has to be at the right time, right? We know that the providers are as overwhelmed as the health plans are. And so if you provide it when I'm coming into a room to see a patient, I'm much more able to take action. This sort of asynchronous communication after the patient's left my office is much more difficult. And then we're all chasing the same thing, which Stephen and I will tell a little story about at the end, but got to be in the workflow to make this really meaningful.
Yeah, and I just want to share, Carrie shared some data with you looking back. I want to share what Medica isolated or identified as their strategic measures of success going forward, and on this moment are using them to really hold us accountable as well. It's a long list. In light of time, I'm not going to go through each one. Instead, I just want to really call out two things about this list. One of the things as somebody who's worked in measurement for a long time that really strikes me is it's limited. There's an adage in measurement, if you try to measure everything, like if you think everything's important, then nothing is important. And I think Medica did a really good job of using metrics here to focus their own people and focus us on the critical things we have to get right to ultimately get to the impact, which is captured really on in the quality column. Which brings me to my second point. When you're thinking about when you're doing something like this, what are the metrics you want to isolate? There's a lot of conversation that goes back and forth between, should I do process metrics? Should I do impact metrics? And a lot of times everybody's like, impact, impact, impact. I think Medica got it right here, and the right answer is both. And you can see that if you go from left to right here, they have really set up measures of success that articulate or illustrate the path to value that we're on with them. So the first set of metrics really go back to what Carrie was talking about up front. We need to build the asset. The second one is, let's be sure now we're using the asset in operations. And then the final column says, okay, we want to be sure that we're starting to see impact. And so I think when you're thinking about what are your strategic measures of success for an initiative like this, I think Medica gives us a great start point. So that's phase 1 and 2. I want to hand it back to Carrie to talk about a little bit more about where we're going with Medica phase 3.
Yeah, I think the one thing I would add here, Stephen, that we see a lot, these are typical, I think, to working in interoperability with our plans, because connectivity is that first step. It is always helpful to say, this is how many more providers we've connected to, this is how much more data. I think one of the interesting parts comes when you start trying to measure operations. And so as just a note and a piece of advice to our teams that are going to take on building out visions like this, is a lot of this stuff like chart pulls and denial rates and chasing some of that are grounded in manual processes that are often not measured now. So one of the really helpful things we often talk about is getting a good understanding of your current state so that you have that ability to go back and compare and contrast. And what we see is when you take the lift off of these business teams and allow some of this to be taken over by digital processes, they're able to chase the next most important thing where we've been focused in the same direction for so long. We lift that, and now it opens up new business optimization opportunities for these teams. But it's really good to know what is today. How many hours of chart pulls? We did 200 last month or last week, and we're going to do 75 this week. Like, those types of pieces of information are sometimes harder to chase later. So it's great to kind of get that as a level set when you're starting to really try and move the needle. So one of the things that I hear often with our health plans is the struggle between getting connected to providers. Some of our plans do the Epic payer platforms. Some work with smaller providers that are on a tail of many different EHRs, and they're doing one-to-one connectivity. But what we often hear is that it's hard to convince the providers there's value there. There's value for us, but they don't really want to work with us. This slide is a great demonstration to prove the point that there is motivation on the provider side to also engage in bidirectional exchange of information, because they also are chasing and spinning their wheels and spending a tremendous amount of time doing manual efforts that really could be captured in a bidirectional, truly interop between plan and provider. So this is our favorite slide. I'm sure you guys are very tired of seeing this slide over and over again, but this is the whole suite, right? This is everything we built. And the most important thing to note about this is once you have this built, Epic was a huge portion of their providers, but they're still planning to connect to other EHRs. So this bottom line where Stephen called out before, where it says other provider EHRs and connectivity solution, means that this system is incredibly scalable. So you can continue to connect to new EHRs, new HIEs, new accountable care organizations. You can continue to grow out your data, your internal data asset, and who you're bidirectionally sharing information with. And then on top of that, you have this ability now, when you're connected to the plan's ecosystem, to rip and replace pieces as needed, right? There's a new part of the ecosystem that needs to be changed. It doesn't mean rebuilding the entire solution. It means pulling one piece out and replacing it as needed. And then I think lastly, what I would click on is, as the regulatory requirements come fast and furious and are constantly changing, this type of a solution set makes you much better positioned to be able to solve for those and not have to continually do what we often say, having worked in health plan world before, this sort of whack-a-mole RFP process of we have a new problem, we need to try and go solve for it. We have a new problem, we need to try and go solve for it. This solution is so robust that allows you to start to do those things without having go back to market each time. So I think this is sort of the big power of what they built overarching. That said, I'm going to show you Stephen's absolute favorite slide of the entire deck. So when we were building this solution with our visionaries and the business leaders at Medica, we talked often about all of the operational impact and the quality impact and ratings and scores, but it always came back to the patient and the member, right? Which is super important to me as a nurse and someone who cared for patients and members for decades. And what we talked about was, what does this really look like at the ground level? Once you put a solution like this in place and you start to really build out a bidirectional exchange and break down the silos of care, how does this really impact our members? And so the story that we talked about was our member here, Mary, who's on the screen, and it's time for Mary to have her mammogram. And I'm sure many people can relate, but Mary is being absolutely bombarded across the healthcare continuum with messages, right? So her imaging centers reminding her health plans reminding her, her primary care physicians reminding her, gynecologist is even reminding her. She's getting postcards, phone calls, text messages. Everyone's reminding her over and over again to close this gap in care and go get her mammogram. But Mary's already scheduled her mammogram. It's already scheduled. So this is incredibly frustrating and confusing for Mary, because if Mary's anything like me, juggling 20 different appointments, she's like, wait, did I not schedule that appointment? Why are they telling me I still need an appointment? And it's incredibly duplicative across the continuum. We're all doing the same effort. Everyone's putting energy and resources into hitting the same button over and over again. And so what Medica really talked to us about and envisioned was this world where we have unified care intelligence, right? Everyone across the continuum is just playing into their strengths. Now we're exchanging data and everyone knows that the appointment's been scheduled. So the providers can focus on what they do best, which is ordering the test and reminding Mary to get the test scheduled. And once the test's scheduled, the plan knows. They no longer need to keep messaging her and telling her to schedule it because it is scheduled, and they can focus on what they do best, which is empowering Mary to actually get to that appointment, have transportation, have any other resources that her plan affords her to make sure she can get there. And then it can all circle back to the provider who can get Mary's results and focus on next steps with her. But this is the difference between the world that Stephen talked about at the beginning, where we're still not in a place where plans and providers are seamlessly exchanging data, and there's all these manual efforts, to a place where everyone knows what they need to know in the right time at the right place to have a big impact on our members and their healthcare. So that's our big story. We thank you all so much for coming today and listening to it. And I think, Stephen, I think we have time for questions. I'll hand it back to our moderator.
Thanks so much. Thank you so much, Carrie and Stephen. And yes, we'll definitely get to questions here. And the first one is asking, one second, let me just get Carrie back on the screen. There you go. No.
Nobody wants to see me, Lisa. You can leave me off.
There we go. All right. So first question is this payer connector and health share and payer services connected to Epic Aura?
I'm going to, can you guys hear me? Am I live?
Yes.
Yes, you're live.
Yeah, I'm going to, the honest answer is we'll get back to whoever asked that question with more specific information. My general understanding is that Epic Aura was designed, and I don't want to speak on behalf of Epic, but was designed to connect providers who are on Epic to labs and genomics and whatnot, as opposed to the payer. And remember, Payer Connector, InterSystems Payer Connector is a companion product specifically to work with Epic Payer Platform to enable that connectivity in and out with payers. So it's a great question. We will go in, get your email, and get back with you specifically about how might this be working with Epic Aura.
Okay, thank you. Next question. What about providers on other EHRs, and how is Medica connecting with them?
I think we tried to allude to it. So they actually have, it's not just one, but kind of a number of things within that connectivity solution. It's kind of a little bit out of our place to start naming names, but they're working with other entities. It's a mix of portals and other hubs to be able to bring in information for those other EHRs. I think the critical thing that is important is that portal and or hub then pumps the information into that one digital source of truth. And I think if Medica was on the line, that would be what they really want to underscore. At the end of the day, we want all that information to go into one CDR because they really want to have one clinical digital source of truth that can then be used for multiple applications. So they definitely want the connection point to be able to ingest that stuff. And as I said up front, right now, with regard to other EHRs, it's more of pulling the information in. Longer term, even with regard to the other EHRs, they're going to want to think through how to get the bidirectionality. But in light of the fact of just the concentration of network providers they have on Epic EHRs, that became a natural start point for them.
Thank you.
I think that was, we talked about the flexibility of the solution allowing for that to continue to collect new data sources, whether it's an EHR or an HIE or whoever. The system is built to allow them to do that. In a world where we're acquiring and merging and, as different lines of business build out and leave, this system really allows you to continue to grow to what's most important to the business.
All right, another question is asking, what do you see as the pros and cons of connecting with providers on Epic via payer platform plus payer connector versus directly?
Great question. I mean, because you can connect directly if you want. I mean, the big benefit here is just efficiency and the ability to kind of get this up and running faster. Because if you're going to want to do all these one-off connections, not only do you have to do one-off connections, but we see there's a lot of bespoke coding that has to go on. That by pairing Epic Payer Platform with Payer Connector together, the overwhelming share of that work has already been done. So that you can kind of push forward or pull forward the bidirectional data exchange. And in fact, you have a lot of these pre-coded adapters because there's still so many different, the information is flowing. I know we all want to move to FHIR, but the reality on the ground today is overwhelmingly the information is flowing and it's going to continue to flow in a slew of different formats. And there are a significant number of proprietary specifications that have to be met for the various systems to ingest different things. And that's both your own proprietary systems, health plan, and also Epic Payer Platform to be able to push stuff back into Epic Payer Platform. So then Epic Payer Platform then can expose it within the provider's Epic EHR instance. Great question.
All right, another question is, do you recommend Medica's phased approach for achieving bidirectional data exchange to other plans?
Yes, I do, 100%. I think in any interop solution, the phased approach is helpful. So you're building on value over time. I think it's easier to position yourselves inside the organization and report out to leaders what this looks like. And it also, just to Stephen's point earlier, when you're doing a big project like this, it's helpful to be able to say what are the goals of each of the steps of the implementation as a check, right? As a say, did InterSystems deliver that? Did we achieve what we were trying to achieve there? And so I think the phased approach is, in general, for these big types of projects with interoperability is the best way to go. But I don't know, Stephen, if you wanted to add anything to that.
Yeah, I mean, I think it's super smart. It's really, I mean, we try to be honest about this. This is, Medica brought this to the table. They had this vision of, I think we shared the larger vision, but they really pushed for, we want a pragmatic roadmap to get there. We want to start getting value. We don't want to, we in effect don't want to be 65% done with everything, but done with nothing. We want to be sure we start to get some value. And the other thing that I really think is very, very important, in today's healthcare market is to flip it around. So it's also really important that when you're making discrete investments, you have that larger vision. This kind of goes to what Carrie was talking about with prior authorization, that it's going to be very, very costly to build a bespoke solution or even contract for a bespoke solution for each individual application. And I think it's really important to start thinking about whether it's quality, whether it's risk, whether it's prior auth. Increasingly, this is all about leveraging clinical data going forward. So I think it's also smart to do the reverse. As you're doing discrete things, to be sure that you have this larger vision so that you're not just optimizing for one application. Each thing you do, you have in mind, how am I going to be reusing? Am I going to be able to support the use of this information for other things?
All right, this person is asking if they have to use HealthShare or can they pair InterSystems Payer Connector with their plan's existing data warehouse?
Yes. I mean, that's, for those of you who haven't worked with InterSystems before, that's just part of our corporate culture, that, we recognize that IT investment can be a significant capital investment, and we try to work with our clients to minimize their own rip and replace. If you've got a great CDR already in place, or for whatever reasons you want to marry our technology to somebody else's clinical data repository, we're very supportive of that. I do encourage people, though, to remember my shopping list, because honest moment, we've had actually in the 0057 space, we've had a number of instances where we started off and we were going to marry our 0057 solution to somebody else FHIR repository. But when we really got into it, it couldn't support it. There are other things that can. Just use the shopping list. Make sure that if you're not using us, you're using a CDR that meets the requirements, that it's going to serve you well, not just in the short term, but the long term. And we're happy to integrate with that CDR.
All right, I have someone asking if a Payer Connector is a managed service or on-prem.
Again, it goes back to what I said. It's either. We want to meet our clients where they're at, and we can do it on-prem, we can do it as a managed service. Whatever works best for the customer is what we'll want to do.
All right, that does look like all the questions at this time, so I'll send it back to you for any final comments or closings that you may have.
Again, I just want to thank everybody for, I know Tuesdays are busy, and I just want to thank everybody for making time to give us 45 minutes to discuss what we feel is a really interesting story about achieving bidirectional data exchange between payers and providers. I think we can all agree that this is just really important, that ultimately, going back to that, one of those kind of pitfalls that Carrie talked about, we've got to move past this kind of tension between payers and providers, and we can all provide better care if we're working off unified clinical intelligence.
And I think Medica said to us that this type of a solution is a game changer, right? This creates parity in a market for regional plans up against the big guys. This is the path forward to really start to make a difference and get healthcare back on track, so to speak. thank you guys all for being here with us today.
Thank you both so very much to our speakers. We thank you for their great presentation and for sharing your thoughts. Thank you to the audience for participating in today's webinar, and this does conclude today's presentation. Thanks so much again, and do enjoy the rest of your day.